Good morning, I am Dr. Biswaroop Mukherjee. Today we are going to do a topic which is very important, especially for your entrances. It's about lymphoma. The term lymphoma identifies a heterogeneous group of biologically and clinically distinct neoplasm which originate from the cells of the lymphoid tissue. Historically, they are divided into two major segments. One is Hodgkin's lymphoma and another is non-Hodgkin's lymphoma. Basic anatomy of the lymphoid system. There are two divisions: central primary lymphoid tissues and peripheral lymphoid tissues. Central are the tissues in which the lymphoid precursor cells mature to a stage at which they are capable of performing their function in response to an antigen. They include two organs, the bone marrow and the thymus. Peripheral lymphoid tissues are the lymph nodes and the spleen. So, central and peripheral. Central is bone marrow and thymus. Peripheral is lymph nodes and the spleen. This is a schematic representation of a lymphoid follicle. These are naive B cells where an antigen comes and binds, and then they gradually change when they enter into the lymph node. These are all the different types of lymphomas which originate from the intermediate stages of maturation of the B cells. For example, multiple myeloma is derived from plasma cells. Now, the comparison between the two major types of lymphoma, Hodgkin's and non-Hodgkin's. Hodgkin's mainly present in young adults. Most of them present early in stage 1 and 2, and usually they present in contiguous nodal groups. Non-Hodgkin's more common in older patients, late presentation in 3 and 4, and because stage 3 and 4 are multiple remote nodal groups are involved, as we will see in the classification. B symptoms is more in Hodgkin's, and these are the nodal groups of thoracic, para-aortic and mesenteric. And these are the extranodal diseases which might involve other organs like CNS, GI tract, GU tract, bone marrow, lung parenchyma and bone. Coming to Hodgkin's lymphoma. It's a malignancy of mature B lymphocytes. It was first described in 1832 by Thomas Hodgkin. In 1898, Carl Sternberg and Dorothy Reed described the features of malignant cells of Hodgkin's lymphoma, now called Reed-Sternberg cells. It originates from mature B cells and represent 10% of all lymphomas. It's more common in whites, bimodal distribution, mainly in the second decade but also in the 7th decade. Males slightly greater incidence, 1.3:1. Highly curable with excellent prognosis. This is the WHO classification of Hodgkin's lymphoma. This is two major classification. One is the nodular lymphocyte predominant Hodgkin's lymphoma, and second is classical Hodgkin's lymphoma. The classical again has four types: nodular sclerosis, lymphocyte rich, lymphocyte depleted and mixed cellularity. Classic type is 95%, while nodular lymphocyte predominant type is 5%. Within the classical type, nodular sclerosis and mixed cellularity are nearly 95%. EBV, the Epstein-Barr virus or EBV, is associated with the mixed cellularity, which is one of the commonest types of the classical type. HIV is associated with mixed cellularity and lymphocyte depleted. Younger patients mostly have nodular sclerosis, while elderly patients have mixed cellularity. All of these points are very important for your MCQ exams. It arises in a single lymph node or a chain of lymph nodes and typically spread in a stepwise fashion to anatomically contiguous nodes. In classical HL, they are recognized by the presence of the Reed-Sternberg cells, while popcorn cells are mainly found in the nodular lymphocyte predominant Hodgkin's lymphoma. These Reed-Sternberg cells are absent. RS cells are large cells with abundant cytoplasm with bilobed and multiple nuclei. It expresses CD15 and CD30. This cell, the bilobed nuclei. Staging of Hodgkin's lymphoma: stage 1, one group of lymph node; stage 2, two or more on one side of the diaphragm; stage 3, two or more on different sides or on both sides of the diaphragm; and stage 4, more than 2 and 3 with extranodal with on both sides of the diaphragm with involvement of other organ systems than the lymph node. This is the stage distribution. Limited stage is 1, 2, advanced is 3 and 4. See, 1, involvement of a single lymphatic site, nodal region, Walde's ring, thymus or the spleen. 2 is involvement of 2 or more lymph regions, lymph node regions on the same side of the diaphragm. 3 is involvement of lymph node regions on both sides of the diaphragm or nodes above the diaphragm with spleen involvement. And 4 is diffuse or disseminated involvement or 1 or more extra lymphatic organs with or without associated lymph node involvement. So, extra lymphatic organs involvement, that is stage 4, irrespective of lymph node involvement, or non-contiguous extra lymphatic organ involvement in conjunction with nodal stage 2 disease, or any extra lymphatic organ involvement in nodal stage 3 disease. Stage 4 includes any involvement of the CSF, bone marrow, liver or lungs. Clinical presents mainly with peripheral lymphadenopathy. Involved nodes are non-tender with no overlying skin changes, discrete and freely mobile. Commonly involved are the cervical and supraclavicular, followed by axillary and mediastinal. Inguinal and femoral lymph nodes are less commonly involved. B symptoms, they are very important. B symptoms are 3: fever, drenching night sweats and weight loss. Other non-specific symptoms are anorexia, pruritus, fatigue and pain after drinking alcohol, but these are non-specific. Pale Epstein fever is fever which persists for days to weeks followed by afebrile intervals and then recurrence of the fever. Diagnostic evaluation: firstly, you will have to take detailed history with attention to presence or absence of B symptoms. Careful physical examination, keeping in mind you have to emphasize the lymph node regions, cervical, supraclavicular, inguinal and axillary, inguinal and femoral. Especially you will have to always see the Walde's ring. You have to tell the patient to open the mouth and see if there is involvement of the Walde's ring, and the size and texture of the liver and spleen. Routine laboratory tests, obviously a complete blood cell count, and ESR, LDH, uric acid, liver function tests, renal function tests, HIV, hepatitis panel. Most important is excision biopsy of the lymph node followed by its immunohistochemistry. HL is a tumor characterized by rare neoplastic cells of B cell origin. Immunoglobulin genes are rearranged but not expressed. in a tumor mass that is largely polyclonal inflammatory infiltrate. Staging workup, PET scan, whole body PET using 8 FDG is standard. It is initially used also evaluation of treatment response. Staging workup, CT scan of neck, thorax, abdomen and pelvis, bone marrow biopsy for finding out bone marrow involvement. Treatment is radiotherapy, chemotherapy, combined treatment modality and supportive treatment. Radiation therapy is the most effective single therapeutic agent for treating early stage Hodgkin's lymphoma. Main objective is to treat the involved lymph node and immediately adjacent continuous sites. Chemotherapy most commonly used is the ABVD regimen, adriamycin, bleomycin, vinblastine and dacarbazine. In early stages, 2 to 4 cycles of chemotherapy combined with radiation is the standard of care. In advanced disease, 4 to 6 cycles of chemotherapy with radiation to bulky residual lesion is standard of care. For relapsed disease, newer drugs are coming in like brentuximab, pembrolizumab and nivolumab. Treatment, patient who relapse after primary therapy of Hodgkin's lymphoma can frequently still be cured. Also, there is autologous and allogenic stem cell transplant which is done with curative intent. Supportive care is mainly treatment of the complications because of the high cell load, complications like tumor lysis syndrome and the superior vena cava syndrome. Coming to non-Hodgkin's lymphoma, non-Hodgkin's are neoplastic transformation of all of them, B, T and NK cells, B lymphocytes, T lymphocytes and natural killer cells. It is mainly distinguished histopathologically by the presence or absence of the Reed-Sternberg cell. Prognosis here is more dependent on histology and clinical parameters than the stage of presentation. It has poorer prognosis as compared to Hodgkin's lymphoma, as complete cure is achieved in less than 50% of patients, whereas 80% of Hodgkin's can be cured. This is the whole classification of lymphoma. This is a Hodgkin's disease, non-Hodgkin's lymphoma. Other disorders of the neoplasia of the lymphoid system is plasma cell disorders, chronic lymphocytic leukemia and acute lymphoblastic leukemia. These are all the different types of the non-Hodgkin's lymphoma. The WHO classification, you will have to remember certain names, firstly divided as B cell and T cell, and these are mature peripheral B cell neoplasms and mature peripheral T cell neoplasms, Waldenstrom macroglobulinemia, hairy cell leukemia, follicular lymphoma, mantle cell lymphoma, DLBCL or diffuse large B cell lymphoma, Burkitt's lymphoma, PEL or primary effusion lymphoma. In T cell neoplasms you get T cell granular lymphocytic leukemia, adult T cell leukemia lymphoma, very important, caused by the HTLV1 virus, hepatosplenic T cell lymphoma, mycosis fungoides, Sézary syndrome, and anaplastic large cell lymphoma, which can be ALK positive or ALK negative. These are the cells of origins, as I said in the previous schematic diagram. All the different types depends upon at which stage the neoplasm is occurring along the maturation pathway of the B cell or the T cell. Epidemiology, slight male to female preponderance, median age is 60 to 65 years, also common in adolescent and young adult patients. The diffuse large B cell lymphoma is the most common histologic subtypes in adults. In children, diffuse large B cell lymphoma or DLBCL, Burkitt's lymphoma and lymphoblastic lymphoma are most common. These are very important again for your MCQs. Conditions associated with development of NHL. All of these, most of these come as questions in a MCQ. Klinefelter syndrome, ataxia, telangiectasia, Wiskott-Aldrich, common variable immunodeficiency, Bloom syndrome, acquired immunodeficiencies like HIV infection, multicentric Castleman disease, autoimmune disorders like rheumatoid arthritis, SLE, Sjogren's, Hashimoto's thyroiditis, inflammatory bowel disease, celiac disease. Chemicals and drugs, very important, phenytoin, TNF agonists, radiation and chemotherapy. Infectious agents, these are very important, EBV, HTLV1, HHV8, H. pylori, Campylobacter jejuni, Chlamydia psittaci, Borrelia especially, HCV, MTV. Infectious agents associated with NHL, Epstein virus is associated with Burkitt's lymphoma. Try to remember this slide by heart. Burkitt's lymphoma, post-organ transplant lymphoma, primary CNS diffuse large B-cell lymphoma, Hodgkin's, HTLV1, as I said, adult T-cell leukemia lymphoma, HIV associated with DLBCL, Burkitt's, Hep C virus associated with lymphoplasmacytic lymphoma, H. pylori associated with gastric mole lymphoma, HHV8 is associated with primary effusion lymphoma and multicentric Castleman disease. The grades: low grade follicular lymphoma, grade 1-2, chronic lymphocytic leukemia, mycosis fungoides. Intermediate grade is follicular lymphoma, grade 3, mantle cell lymphoma, DLBCL, T NK cell lymphoma, peripheral T cell lymphoma, and anaplastic large cell lymphoma. High grade, remember these two names, Burkitt's lymphoma and lymphoblastic lymphoma. Clinical features: low grade lymphomas present with peripheral adenopathy that is painless and slowly progressive. Spontaneous regression of enlarged lymph nodes may occur. Primary extranodal involvement and B symptoms are not common in patients with low grade disease. Intermediate or high grade is peripheral lymphadenopathy. 30 to 40% of patients present with extranodal involvement like skin, bone marrow, CNS, and gastrointestinal tract. B symptoms are more common. Lymphoblastic lymphoma often manifests with an anterior superior mediastinal mass or SVC syndrome. Involvement of retroperitoneal, mesenteric, and pelvic lymph nodes is common. Diagnostic evaluation: history and physical examination, all the peripherally accessible sites of lymph node, the liver, spleen, Walde's ring, any evidence of pleural or pericardial effusion. Testicular examination, neurological examination if CNS involvement is suspected. Bone marrow biopsy, CSF study in lymphoblastic lymphoma, Burkitt's lymphoma, and DLBCL. Biopsy from lymph node or extranodal site, excision biopsy, histopathology and immunohistochemistry. Lab investigation same as Hodgkin's. Radiological, CT scan, PET scan, MRI scan. Staging almost the same as Hodgkin's itself. Involvement of a single lymph node or single extranodal site. Involvement of two or more lymph regions or lymphatic structures on the same side of the diaphragm alone, or involvement of limited contiguous extralymphatic organs. Stage 3 is involvement of lymph node regions on both sides of the diaphragm, which may include the spleen or limited contiguous extralymphatic organ or tissues or both, and diffuse or disseminated foci of involvement or one or more extralymphatic organs. This is a prognostic, international prognostic index. 5 clinical risk factors are age more than 60 years, LDH elevated, ECOG or Karnofsky performance, ECOG score more than or equal to 2 and Karnofsky less than or equal to 70, Ann Arbor stage 3 and 4, and more than one site of extranodal involvement. Treatment: chemotherapy, CHOP regimen. Drugs used are vincristine, cyclophosphamide, doxorubicin, and prednisolone. Targeted therapy: non-Hodgkin's like rituximab and ibrutinib. CNS prophylaxis with intrathecal methotrexate in high-risk patients. Radiotherapy is indicated for bulky disease. These are some of the special subtypes. DLBCL comprises of 31% of all NHL, most common histologic subtypes. Extranodal involvement is common, including GI tract, testes, bone, thyroid, skin, CNS. highly invasive with local compression of blood vessels, airway and involvement of peripheral nerves, destruction of bone. Dual BCL immunohistochemistry is CD20 plus, remember that. Follicular lymphoma, second most common lymphoma, 20% of all NHL, consists of mixture of centrocytes and centroblasts. Long-standing lymphadenopathy which waxes and wanes over the years. Bone marrow involvement is present in 70%. Involvement of other non-lymphoid organs is uncommon. Burkitt's lymphoma, very important, aggressive lymphoma, 30% of childhood non-Hodgkin's lymphoma. Two forms, the endemic African form, presents as a jaw or facial bone tumor that spreads to extranodal sites including ovary, testis, kidney, breast and especially to bone marrow and meninges. Non-endemic form has an abdominal presentation with massive disease, ascites, renal, testis and ovarian involvement. Tumor cells are positive for B cells antigen CD19, 20 and surface immunoglobulins, uniformly positive for CD10 and BCL6. Endemic lymphoma are EBV positive, only the endemic form. Highly chemosensitive. It incorporates usually high doses of cyclophosphamide. Prophylactic therapy to the CNS is mandatory. Mantle cell lymphoma, malignancy of small to medium sized B cell in the mantle zone. Typical sites of involvement are lymph nodes, spleen, liver, Walde's ring. Majority of patients with mantle cell lymphoma have a disseminated disease requiring treatment. Chemotherapy is the primary treatment modality. Thank you.